about Achilles tendon rupture and being a disease of middle-aged men, and I think the acid test here is if I'd like each of the panel members to tell me if their 40-year-old brother, who's a recreational athlete and wants to run in a triathlon next year, has ruptured his Achilles tendon, are you going to tell him he can go conservative or are you going to operate on him? Dr. Carlson?
Actually, there is no good answer to this because both things may work very well. If you asked me this a couple of years ago when we did the second randomized study, I would say conservative. Today, I would say surgical, because we had 0% re-rupture and it really works very well. But looking at evidence, there is either way.
Same answer. We go for surgical, even if there is no evidence. But I'm a surgeon, so.
And it's unlikely I'm going to disagree with you. The only thing I would say is that if you, at 40 years old, you know, I'd give them the options. I'll discuss it with them and give them the options, I think.
I think it's very important to explain very well to patients that there are two options and that they should be very central in the decision process themselves. Then you might also, you know, 40 years old, maybe it's a young person, maybe it's not middle-aged.
Well, I certainly appreciate that thought as a 45-year-old. Now, we have a question here.
What is the limit for early mobilization after surgery for Achilles tendon repair? Is the limit that for the strength of the sutures, or is it because you are afraid that the tendon will be too long and don't be functional anymore?
I think you bring up a very important point about the length of the tendon, because this is something that we cannot measure very well today, and we measure it with a very crude measurement with a range of motion with a goniometer, and I think that the lengthening of the tendon is highly correlated to inferior result. So I think strong suture, good repair, and early range of motion, that's fine. I don't think we really need any plaster or any immobilization. Maybe a graded mobilization after that. Probably don't need it at all if you just use some common sense. But I think that one of the issues that we need to do much more research on, and we are doing today in my group, is on the minor lengthening. Maybe is a centimeter or 8 to 12 millimeters, something like that, because I think that's very highly correlated to inferior result in terms of reduced strength and also return to sports.
In your last series, you showed us that you use a free graft, gastrocnemius. How do you take it? Is it allograft or take it from the top?
I take it from the patient himself.
Because your incision was a small.
The incision will be quite long. You can actually use 2 incisions if you like, but this incision I showed it was quite long. But we have studied this and we have published on this, and this actually works very well. So in the study we did, it was about 30 patients. This little less than 30 patients. We had actually 0 re-rupture.
And when you augment all the cases, or when you feel that the ends are shredded and you're not happy with the repair?
No, we are actually using this method for every re-rupture we are operating on. Then there are several re-ruptures that we don't operate on because the risks are so high, like varicose veins, smoker, diabetes, etc.
I think he was talking about your last technique for the primary rupture with you said you used 2 flaps?
Yeah, there's just very short local flaps, and not the big gastrocnemius. Sorry, I misunderstood you. There's a very short local flaps. We turn them up, turn them down.
It's a turn down flap.
Yeah, but they're very, very, very short. I would like to ask James, because I know that you have extensive experience with the Achillon.
Reasonable amount, yeah. I mean, we've now got 3 studies out on it and a biomechanical study, because I was worried that it isn't going to be as strong and it's not going to allow you to do the early aggressive rehabilitation. unallowed orthopedic surgeon. Yeah, I was worried that you weren't going to be able to do the aggressive rehabilitation, but biomechanically, on sheep tendon, admittedly, it's as strong as a Kessler suture. So it should allow you, and there's no gap formation with it. So I'm pretty happy with it. And we've now got up to 380, just under 380 patients prospectively. So there's a reasonable number there. But I was going to ask about there's the Canadian study, which everyone quotes at the moment, which has got huge issues, and I'm not going to go there at the moment. I'll go there in the American Academy next year. We'll take that apart there. But with the conservative management, do you feel there's a role for doing an ultrasound at the time? You know, if there's a gap, how big a gap can you have? And then also, during the functional rehabilitation, no one's looked at lengthening of that tendon there, but okay, if you get an elite athlete, you put him into Aquinas. Well, I guess you're not going to treat him conservatively, but you know, most people come through our emergency departments. They may have had it for a few hours, a day, 2 days before they get sent in, maybe a week. And I reckon they've got a big hematoma and a big hole there.
Actually, this is something that we don't know. You know, first the Canadian study are talking about Willets and Amendola, and I think that Sandy Kirkley was actually involved in starting up the study before she died 10 years back. So, and in that study, it's almost 150 patients. There were 3 re-ruptures in the surgical group and 2 in the non-surgical group. No, vice versa. Regarding the ultrasonography, it was for example, by Terman in Hanover, and it's a very good idea, but you really don't know the size of the gap that you can accept. Is it 1 centimeter, 2 centimeters, or whatever? And it's also a little bit variable, so it really needs more studies. However, I think that the gap is of importance because the gap will create longer tendon, and longer tendon will probably create less force and less good result. And this is something that we really need to know more about. I think that we know enough about surgery versus no surgery. It is about 3 or 4% versus 10%, something like that. It will not change very much. It is there. We know that percutaneous with good technique is good, and probably the nerve injuries, they are not that terrible. And that's probably good. And I think that we should move away from using re-rupture as the most important primary variable in our studies. Function is the important variable. How people are you know, we should use a score, for instance, the Achilles tendon score as a primary variable instead of re-rupture. I think that's done, really. We don't need more studies like that. I think that this is really the next big important step when we are exploring Achilles tendon ruptures. That is the tendon lengthening and the effect of tendon lengthening on function. And we really don't know this, and this is much more important than still another study on 100 patients that I can be doing myself. There's a bit of criticism, of course, but that's science. Okay, I completely agree with you and you.
I think Jay might have.
Yeah, Dr. John. Yeah, do you have any data recording or regarding how did that happen, the re-rupture, or where did that happen, in the rehab, at home?
You know, re-ruptures, they always happen fairly quickly after either patients are non-compliant, like they do something that they shouldn't do, like playing beach volleyball in the sand 3 weeks after suture or something like that, or that it happens due to very, very limited trauma after the plaster or brace is removed, say in week 9, 10, 11. We have never had re-rupture after week 18 in all the studies we have done. And re-ruptures, they never happen late. And then they happen after very limited trauma. Maybe you just take something off the floor or something like that. And my theory is that the tendon is never healed. There's a acute arthrosis in the tendon ends, and I operated on several of these, and the ends are rounded off.
Just to move with the same discussion, you told us that there is no difference between surgery and non-surgery in terms of return to sport.
In the first study we did, yes.
Yeah.
54%. Provided we excluded the re-rupture.
Yeah, this is my point. So you exclude the re-rupture, and you tell that the re-rupture are early re-rupture. So it means there is really a difference in terms of return to sport between the two group.
No, I have to be honest about that. We excluded the re-ruptures. So those patients who didn't have a complication, because there were some patients in the surgical group that had a complication like wound infection, etc. It was not major, but some. If we only had patients included who had no complication, okay, minor complications were included, like skin adhesions or something like that. But then the rate was similar.
Based on this remark, it means we have to detect. It means maybe we have to detect among the conservative treatment those who are at risk to a re-rupture. And maybe it's the point that you raise about the gap between the two tendons.
I think that's very probable, and we also should try to recognize those patients with lengthening, excessive lengthening of the tendon, and do it early, because they will probably not have good function, and they might need surgery in order to shorten the tendon. I've done it several times, but you know, and you've also done it several times, I know. Yeah, but the indication is in the air. So we are actually working on this quite a lot now, and we're doing this with a very, very sensitive ultrasonography, and we can measure the tendon lengthening down to the accuracy of 1 millimeter with a comparison with the other side. Sorry?
If you have a neglected tendon-Achilles rupture after 2-3 months, do you do VY lengthening only, or do you maintain your infection?
No, if I have a neglected rupture, I do the surgery I showed you. I showed on the slide with the gastrocnemius flap. Yes, both for re-ruptures and neglected.
You don't do VY lengthening?
No. Okay, there might be other techniques, and I can do some other techniques. And if there is something, if the tendon is ripped off bone, for instance, you have to do something else. And then I would probably use a free semitendinosus, something like that, and drill it through the Achilles, through the calcaneus. But that's another story. I think the gentleman behind you had a question. No.
Yes. Excuse me, for John, actually. I'm with you that there is the tendon. I'm with you that the tendon is like repairing of the tendon, that there is no inflammation in the tendon. And this is maybe there is some like lacking of healing process in the tendon unless you have to do the surgery. But whether if you do the surgery, whether there is any means just to let the tendon heal up by the surgery that you are doing, and whether this is, again, with that lady about the lengthening of the tendon and the muscle, like the or tendo-muscular junction, whether it's going, because the muscle going to contract. Even after the surgery, the muscle become shrunken and contract, and need rehabilitation just to like retain the elasticity back to the tendon. But whether the healing process takes a place if you are doing the suturing of the tendon?
Yeah, I think it also depends on the rehab. You know, I think that I think the important thing in this is to get the rehab going early, and we've also noticed that early weight bearing is very beneficial. I don't know really, and probably nobody knows the effect of tendon healing. And as I mentioned, I've seen some of those with a thickened paratenon, but no tendon healing inside, like rounded off ends. And I see that James has also seen this. Yeah. So then my guess is in that case is that those tendons, they never healed. They didn't have the capacity, or the inflammation didn't lead the tendon to healing. The only thing that healed was the paratenon and not the tendon. And then they, it's just a matter of time until we have re-rupture.
Our last question,
Yeah.
Felipe.
What do you think about PRP?
Oh, I never use it.
I know Willits, Kevin Willits in Canada wanted to start randomized comparing functional treatment and functional treatment plus PRP, but he had to stop because everybody was asking for PRP.
I know. We talked about it. I know Kevin very well.
Okay, I think we'll finish it up there, and I'd just like to take the opportunity to once again thank our organisers, our speakers, and you guys for coming in.